Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Professor Eric Lim, and this is Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and our affiliate partner, Medela, the Science of Care. This week, it's a great delight for me to present one of the world's most renowned authorities on non-smoking lung cancer, chief investigator of the Talent Trial, and with so much data that we've already started discussing even before the webinar has started. It's a great delight to present a colleague and a good friend, Professor Pan-Chyr Yang. Pan-Chyr, over to you.
Okay, thank you, Professor Lin, for kindly inviting me. So my talk today is screening for non-smoking lung cancer. So this is the key message for today's talk. Non-smoking lung cancer is increasing, is an emerging global health threat, and non-smoking lung cancer actually is a totally different disease, and it is prevalent in East Asia. And then I will talk about the molecular pathogenesis and also the risk factors for non-smoking lung cancer. And then how about the feasibility? Can we screen non-smoking lung cancer based on the risk factors? I will show some evidence. And then finally, and we show that actually the screening for non-smoking lung cancer is feasible, and we can actually see the stage shift and also the mortality reduction from those city screening. So actually, we all know that smoking-related lung cancer is the #1 cause of cancer mortality worldwide. But you look at the non-smoking-related lung cancer, actually it ranked 5th in the global cancer mortality. It's even higher than colon cancer, esophageal cancer, pancreatic cancer. So you can estimate that actually more than 30% of lung cancer patients, actually, they did not have smoking history worldwide. Actually, in East Asia, Asia has the highest disease burden of lung cancer in the world. Around 63% of lung cancer occur in Asia, and 63% of lung cancer mortality occur in Asia. And especially in East Asia, around 50% of the lung cancer worldwide actually occur in Asia, and 47% of lung cancer mortality occurred in Eastern Asia. So Asian has highest disease burden of lung cancer. But if we look at the smoking prevalence, in male, most of the male lung cancer patients, they have smoking history. But in female, especially in Eastern Asia, you can see the smoking prevalence is very low in lung cancer patients in East Asia. In the Europe and United States, in female lung cancer patients, they still have high smoking history, around 70% to 85%. But in Eastern Asia, you can see in female lung cancer patients, most of them, the smoking incidence is very low. In Taiwan, it's only about 5.9%. In China and Singapore, you can see all are the same. Most of the Eastern Asian country, the female lung cancer patient, they did not smoke. And this is the smoking prevalence and lung cancer mortality in UK. You can see here, lung cancer is the #1 cause of cancer mortality, both in men and in women. And you look at the smoking prevalence, and in male and female, it is decreased tremendously. So actually, lung cancer does not decrease in line with the smoking. So in UK, also show the data, pretty similar that non-smoking lung cancer seems to increase. And in United States, it is the first time you can see that the lung cancer patient, the incidence in female is higher than male. But actually, the smoking prevalence in female adult is less than male. So it is very strange that female lung cancer seems increasing worldwide. This is in South Korea. Lung cancer is the leading cause of cancer mortality, both in men and women. The smoking prevalence in men is still around 39%, but in female, it's very low, only 3.3% smoking prevalence in adult female. And in Taiwan, it's the same, very low female smoking prevalence, but lung cancer is the leading cause of cancer mortality in women, same as in men. So our problem is that in our lung cancer patient, it is the leading cause of cancer mortality, and non-smoker is higher than smoker. 2/3 of our lung cancer patient, actually, they did not have smoking history. Only 1/3 of them, they had smoking history. And very high female to male ratio, nearly equal now, and very high adenocarcinoma. And in women, 94% of lung cancer patients, they did not have smoking history. And half of them, they are stage 3 or stage 4 disease, more than half of them. And we start to estimate the smoking contribution to the lung cancer patient. In males, around 27%, and in female, it's less than 5%. So actually, the increase of lung cancer, especially in adenocarcinoma, cannot be explained by smoking alone. So this is the risk factors. We found that some of our data shows that actually the risk factor for in non-smoker lung cancer, they have some exogenous factors, including especially the air pollution, secondhand smoke, and also radiation exposure and others. But some endogenous factors very important, family history especially, and some germline defect, especially the alphabet signature. I will show some of them, and also SNPs associated with the germline accessibility. And we found that the female gender in East Asia, this seems to have high risk. So because we have so many non-smoking lung cancer and the incidence is increasing, so the government support us to join the Cancer Moonshot project initiated by NIH in the United States. And in this particular project, we found that some pathogenic mechanisms that are quite unique in non-smoking lung cancer, especially in Eastern Asian population. We have very high EGFR mutation and never-smoker, modern smokers, and relatively early onset. We found that some endogenous factors, especially the alphabet signature, which may associate with smoking lung cancer, and also environmental carcinogen signature, especially the nitropolycyclic aromatic hydrocarbon and also nitrosamine. Both of the commonly seen in air pollution, and nitrosamine also used as a food preservatives in Eastern Asian region. And chromosome 7p is very, very important. And this is the driver mutation for non-smoking lung cancer. You can see they are quite different. We have very high EGFR mutation and followed by RBM10 and others. And this kind of the driver mutation is quite different from the TCGA, the smoker population. So actually the driver mutation are quite different. And chromosome 7p is very, very important. We know that chromosome, the EGFR gene actually located in chromosome 7p arm, and it is very common in Eastern Asian region. And in a in the early study, we found that the copy number alteration is very, very common in the chromosome 7p. And in this carcinogen signature, especially nitropolycyclic aromatic hydrocarbon and nitrosamine, actually this environmental carcinogen signature are enriched in chromosome 7p. That indicates that the carcinogen signature is located very close to the EGFR mutation, EGFR gene loci. So indicate that may have some association with the EGFR mutation in adenocarcinoma in non-smokers. So there are some SNPs associated with the risk of non-smoking lung cancer. We started this project very early, collaborate with NIH. We have a big cohort for that. Actually, totally, there are around 25 loci has been identified associated with the risk of non-smoking lung cancer in Eastern Asian region. So we hope to develop a polygenic risk score that can help us to identify the high-risk population. Maybe they can benefit from low-dose CT screening. This is our current project we are going on. And family history is very important. We did many family history study here. This is a typical example. Actually, we found YAP1 oncogene is associated with familial lung cancer. And in this family, you can see both father and mother die of lung cancer, and 4 daughters, they are lifelong non-smokers. They are confirmed to have lung adenocarcinoma. This is a CT scan image of the mother and the 4 daughters. The only son is a heavy smoker. He did not have lung cancer yet. Odds ratio for YAP1 oncogene is very high, up to 5.9. We follow the subject with family history of lung cancer from 2007 to 2011. We follow more than 1,000 subjects. They have family history of lung cancer. We found that the cumulative lung cancer detection rate up to 4.5%. If we follow for 10 years, then the cumulative lung cancer incidence is up to 4.5%, especially those with multiplex family. That means that they have multiple family members who had lung cancer. The risk may increase to up to 7.7%. In only those with one family members, then the risk would be around 3.4%. This is not unique in Eastern Asian region. Actually, a recent study in New Zealand, they also found that in those non-smokers with lung nodule, family history is a very important risk factors. So there are some meta-analysis try to look at the risk of lung cancer, especially in non-smoker in Eastern Asian region. It is very interesting, and to find that actually in the risk of non-smokers is similar to ever smokers in Eastern Asian region. That is quite different from non-Asian. In non-Asian, smokers have higher risk for lung cancer, but in Asian, especially in Eastern Asian, actually the the risk for ever smokers and non-smokers actually are similar. So air pollution is associated with the EGFR mutation. You can, in this study by Charles Blunden, you can see actually the EGFR mutation is associated with the correlated with the PM 2.5 exposure. It seems that higher PM 2.5 exposure, they increase the prevalence of the EGFR mutant lung cancer. So actually, we recently write a review article, try to look at the current evidence that air pollution and the lung cancer progression, especially the EGFR mutant lung cancer. Current evidence suggests that the air pollution, especially PM 2.5, through the inflammation, oxidative stress, and DNA damage, they can start to create some DNA damage, and because of the they can also inhibit the DNA repair. In some susceptible patient, they can create the DNA damage, and through the EGFR, through the area hydrocarbon receptor, and also they can activate the oncogene, especially the EGFR driven lung cancer patient. And the cytokine, especially the IL-1 beta and also others, IL-18, they are involved in this the PM 2.5 promote lung cancer progression, the process. So because with this background, we start very early the low-dose CT screening because we have non-smoking lung cancer higher than smoking-related lung cancer. So we focus on the non-smokers. This is the Taiwan study. We focus on never-smokers, have family history of lung cancer, passive smoking, chronic lung disease, high cooking exposure, high cooking index, or cooking without using ventilation. We recruit 12,011, half of them with family history of lung cancer. And this study nearly finished. We found that the first-round lung cancer detection rate is very high, 2.6% higher than anesthesia Nelson. And even we just consider the invasive lung cancer still very high, 2.1%. And the 96.5% stage 0 to 1. If we only consider stage 1 disease, it's still very high, 77.4%. And those with family history of lung cancer may increase the risk of lung cancer. So it's just like a dose-responsive curve. If family members, more family members with lung cancer, the risk of lung cancer increase. And multiple primary is very common in non-smoking lung cancer, just like this. Totally, around 18% of them in Taiwan study, multiple primary lung cancer, or confirmed to have lung adenocarcinoma. And some of them, even very small ground glass nodule, still confirmed to have the invasive lung adenocarcinoma. And usually this kind of ground glass nodule, especially non-smoker, they progress very slowly. This is a typical example. It takes around 10 years to grow to a very big size. And this patient actually is EGFR mutant tumor and develop widespread metastasis at diagnosis. And if we think we have a good screening strategy, we can detect lung cancer earlier and resect the tumor. Probably we can cure this patient. Actually, this patient, even with EGFR mutant, after very extensive target therapy and the chemotherapy, the patient still died 2 years after diagnosis. So we convince our government we need to screen for lung cancer. We cannot just focus on heavy smoker because only 1/3 of them, they have smoking history. 2/3 of them, they did not have smoking history. So the government was convinced to start the low-dose CD screening from 2022, July. We aim to double the stage 1 disease and 5-year survival by 2030s. It is a biannual CT. Every 2 years, we have a low-dose CT paid by the government, focused on 2 population, smokers, 30 pack years. We now reduced to 20 pack years from 2024, and those with family history of lung cancer in non-smoker or light smokers. We choose relatively 5 years earlier for female non-smokers. Overall, you can see here, we already screened nearly 150,000 of them right now. The lung cancer detection rate is 1.2% and 83.3% stage 0 to 1. If we look at the heavy smoker, the detection rate is only 0.8%. But those with family history of lung cancer, especially non-smokers, up to 1.7%, and nearly 90% of stage 0 to 1. That means that they are potentially 90% of them, they are curable. And overall, for those with family history of lung cancer, is 1.6, and again, around 90% of them, stage 0 to 1. If those subjects with 2 both risk factors, heavy smoker with family history, it is very interesting. Only 1.1% of detection rate, just in between. And if we stratify by the gender, you can see here in heavy smoker male, the only detection rate is 0.7% and 67% stage 0 to 1. In those non-smoker female, the detection rate up to 1.8%, and 91% of them are stage 0 to 1. So it seems that for non-smoker with family history, those female subjects may be more beneficial for the benefit by the low-dose CT screening. So how about the stage shift? Before low-dose CT screening, we can see that 50% of them are stage 4 disease. And by low-dose CT screening, you can see the stage 4 disease can reduce from 50% to 7%. And both in, especially in family history of lung cancer, you can see only 4% of them are stage 4 disease. So we are assume that we estimate that actually we can reduce advanced disease by 74%. And because the early disease patient, they can survive much better. So we predict to reduce the lung cancer mortality by 53%. So we recently just finished the lung cancer cumulative mortality study. We use a pseudo control, but AI to generate the control group, and this group age 6 matched and the risk factor matched. I can see here in those with family history, many non-smokers, we can achieve 67% of reduction in mortality. In smokers, heavy smokers, 36%. In Nielsen, it's about 20%. In Nielsen, it's about 24%, and RST 20%. And in our study, it seems that we can reduce around 36% lung cancer mortality in heavy smokers. So this is my conclusion. Non-smoking lung cancer is a new emerging disease worldwide, especially in East Asia. PM 2.5 may play a very important role. So far, although we have some SNPs or genetic susceptibility factors, but the most simple one would be the family history. They can help us to identify the high-risk group. They can benefit from low-dose CT screening. So lung cancer screening for non-smoker may need a different strategy. And our preliminary result in first 2 years, we found that we can reduce 74% advanced disease, and we can estimate to reduce around 50% of lung cancer mortality. Thanks for your attention.
Amazing. Thank you so much, Pan-Chyr. Also, thank you for leading the world in the field of screening for non-smoking lung cancer. Maybe I'm going to start with some generic questions. Do you have a risk model developed in Taiwan for non-smoking lung cancer that gives you the percentage risk?
Yeah, actually, yes. In our National Health Research Institute, Professor Xiang, she developed a risk prediction model. You can use the app and the nodule detected by the low-dose CT and your age, sex, and also some demographic information. You can estimate the risk. We are continuing to improve this prediction model. We hope that this prediction model can help the general population to estimate their risk.
Excellent, thank you. And can I ask, how did you select the age of 45 for women in Taiwan for non-smoking lung cancer screening? What percentage risk roughly would that translate to at age 45?
Yeah, actually, the peak age for the male patient is around 65. And the female is around 60. It's about 5 years younger. But look at our cancer registry. We still have many patients, especially in women, non-smokers, and family history. The lung cancer tend to occur earlier. About 5% of them, around 5% of them actually. And then so the government's because of some gender consideration, they think that we should screen the female subject with family history of lung cancer 5 years earlier. Actually, we allow those if the indicates the age is younger, then the family members young at that age, we also provide the free low-dose CT for lung cancer screening. even less than 45.
Excellent, very good. There's a question from Anand Patel. For female non-smoking lung cancer, is the disease more aggressive than smoking lung cancer itself?
No, actually, no. They usually, as you know, that many clinical trial, they found that in female gender, actually the survival is better than men. So the lung cancer in especially non-smoker, they tend to progress relatively slow. So usually the outcome for female is not worse than men. No, the outcome is better than this if age matched and the risk factor smoking matched, then the outcome for female lung cancer is better than men. And another explanation is that they have relatively high EGFR mutation. They can benefit from the target therapy.
Pan-Chyr, one of your slides, you put there your current data for smoking in Taiwan, about 30% of men and less than 1% of women. And yet the presentation for lung cancer is almost 1-to-1. Does that suggest that
Yes.
women are around 30 times higher risk given that they are non-smokers?
Yes, this is why a puzzle we don't understand. So we are trying very hard to know why in female they are high risk, even they did not have smoking history, and some environmental factors, including the cooking index and uh, some occupational exposure. We try to explore that. But we cannot find that they are associated with the risk. But the PM 2.5 seems they increase risk in female gender. It is very strange, and we found that especially in alphabet signature, this is more common in female gender non-smokers. So that seems that some endogenous factor may play a role. We also think about the female hormone. Do they have some interaction with this kind of the environmental carcinogen? Actually, we don't have data yet.
Pancho, there's a question from Professor Paul Bass, who's asking about the link between air pollution and EGFR mutant lung cancer. Now, Charlie Swanton presented here on the Grand Rounds before this hypothesis and theory, but it cannot explain all of the non-smoking lung cancer because the ratio for women to men are so much higher. If air pollution was an important factor, then surely the gender ratio would be the same.
Yes, there are still a lot of unknown, the lot of the we don't know why in female they are more susceptible. So we do think that some endogenous factor may play a very important role.
Yes, some questions from Mr. Adrian Marchbank, who's asking, with the non-smoking lung cancer, would you recommend lifelong follow-up by CT screening after lung cancer resection?
Yeah, I would suggest, yes, they need a long, they need a follow-up, but how long we should follow up the patient may be debatable. Usually the low-dose CT screening, usually we have the age limit of 75. Some of the study can up to 80. So probably you should follow the patient up to 75 or 80. Yes.
Yeah, because your
Yes,
results will.
it's a good suggestion. Probably you'll convince our government to do that. Even after resection, they should still follow the patient by every 2 years low CT.
Yes, I mean, clearly Taiwan is always leading the world in this field. Before we went online, we were discussing very briefly about the French study that showed that CT screening after lung resection didn't actually improve survival. Whereas for the data from Taiwan suggests that even in non-smokers, for the 2-year interval, it seems to be very effective. Do you have any thoughts on this subject?
Yeah, I think we probably have data already. I actually after resection, our surgeon usually they follow the patient very very actively. They follow the patient every 6 months, and then every 1 year. And usually they follow the patient up to 5 or 6 years. Probably they still follow this patient. I can retrospectively archive our resected lung cancer patient to see the lung cancer instance in those resected lung cancer patient. Probably we can get some message that we should follow them to improve the survival.
Thank you. Final question from Dr. Jens Ruckert, who's asking, how much CT radiomics or AI do you involved in your screening program for non-smoking lung cancer?
We have some locally developed AI to help the radiologist to develop a structure style report. And we also participate in the, the CBER, algorithm for lung cancer detection developed by the Regina and MIT. Actually, that program was supported by Quantum Computer Taiwan. So right now, actually, we are initiating a multi-center study, try to use the SYBIL, SYBIL, the AI algorithm to help us to stratify the risk from the first low-dose CT screening. I explain here. The cyber AI, they are able to use the first low-dose CT image and then to stratify the risk in the risk of lung cancer in 6 years. So probably you can use that AI algorithm help to stratify how long we should follow the patient based on the risk. We are trying to
Excellent.
answer that. Yes.
Excellent. Thank you so much. And once again,
Yeah.
obviously we have so many questions and not enough time for answers. So thank you to our sponsors, AstraZeneca and Medtronic, and Medela, the Science of Care. Next week, we're going to talk a bit about something different, lung volume reduction surgery and endobronchial valves with Professor Nick Hopkinson from the Royal Brompton Hospital, which leads me once again to thank you, Pan-Chyr, so much for leading the world in screening for non-smoking lung cancer and developing new ideas, research to continue your advancement in the understanding of the disease. Thank you so much, and thank you for your presentation today.
Thank you. Thank you, Professor Lin. Thank you.
Bye-bye, everybody.
Bye-bye. Bye-bye.